أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم.
وأيوب إذ نادى ربه أني مسني الضر وأنت أرحم الراحمين فاستجبنا له فكشفنا ما به من ضر وآتيناه أهله ومثلهم معهم رحمة من عندنا وذكرى للعابدين وإسماعيل وإدريس وذا الكفل كل من الصابرين وأدخلناهم في رحمتنا إنهم من الصالحين وذا النون إذ ذهب مغاضبا فظن أن لن نقدر عليه فنادى في الظلمات أن لا إله إلا أنت سبحانك إني كنت من الظالمين فاستجبنا له ونجيناه من الغم وكذلك ننجي المؤمنين وزكريا إذ نادى ربه رب لا تذرني فردا وأنت خير الوارثين فاستجبنا له ووهبنا له يحيى وأصلحنا له زوجه إنهم كانوا يسارعون في الخيرات ويدعوننا رغبا ورهبا وكانوا لنا خاشعين.
جزاك الله. بسم الله الرحمن الرحيم. اللهم صل على سيدنا مولانا محمد وعليه بارك وسلم عليه. We will begin with Dr. Zishan Khan's talk today. Thank you all for joining. In the interest of time, we'll skip the intro, which will take another few minutes, but Dr. Zishan Khan is our consultant in the northern part of Peshawar, a part of Pakistan, which is Peshawar. So Dr. Zishan, without wasting further time, please go ahead.
Good morning and good afternoon to everyone. I'm Zishan Khan. I'm an orthopedic surgeon working in the vibrant city of Peshawar. And I'm going to be talking about investigating a pelvic lesion. So whenever we talk about orthopedic oncology, we brush aside quite a few things, and mainly it's because of the rarity of this disease. And because they're rare, there is lack of training in them. There's a big learning curve. There's a big fear of failures. Infrastructure is quite bleak, if we are to be honest, particularly in the the underdeveloped countries like ours, and it is very less lucrative. So it is kind of that white elephant in the room. So let's take, for example, this X-ray of the clavicle of a skeletally immature patient in whom you can see the swelling and extensive periosteal reaction in the clavicle. You might think this could be infection or a Ewing sarcoma, and we both know that they mimic each other quite regularly. But when you look at the X-ray of the similar patient on the other side, you see that this patient has also got similar changes in the clavicle. So here, easily, it's given away that this is a chronic reactive multifocal osteomyelitis rather than a Ewing sarcoma. So it is confusions like these that makes us worried and concerned. So on the picture on the left, this is an infection, and the picture on the right, you can see that there is a Ewing sarcoma. So again, quite similar pictures. Picture on the left, you can see a skeletally immature patient where there's an aneurysmal bone cyst, typical soap bubble appearance. But here you also have to bear in mind that you have to rule out a telangiectatic osteosarcoma because it can present with a similar appearance. On the contrary, on the right side, you see a similar type of lesion in the pubic ramus, but here there is a skeletally mature patient. So the history and the age is slightly changing, although the lesion appearance is slightly similar. So here the histology was GCT with secondary aneurysmal bone cyst changes. So as you can see that it is the radiological similarities and the differences in the age and the presentations that will make a varied diagnosis, which is why this field is slightly more interesting. I do apologize about the poor quality of this picture, but there is a good message behind this, and I'm going to show it to you when we talk about the role of intervention radiology. Here, you can see on the arrow that in this skeletally immature child who's been going around seeing different orthopedic surgeons for the last 3 years with pain in the right hip sort of the sacroiliac region, and he's been having x-rays and they've been ignored, whereas if you can see on the arrow, there is a nice sclerotic lesion around that area. So we have to be mentally prepared and be well versed with different pathologies and different appearances on x-rays to make sure we don't miss on anything, which is the commonest problem with musculoskeletal tumors because there is a delay in diagnosis, and most commonly they have been going through generalists, so they end up having inappropriate investigations leading to wastage of time, sometimes inappropriate treatment, which is indefensible and inexcusable. So if we look at the SEER data, this tells us that only 3% of all the tumors reported in that data were bone tumors. So they are not that uncommon. If we look at the age distribution of bone tumors, we see that usually the malignant bone tumors have a bimodal age distribution, particularly in the Ewing sarcoma. They are either in the pre-teen years and then in the ages between 20 and 30 as well. Osteosarcoma also has a bimodal age distribution, more common secondary osteosarcoma after the ages of 40 and 50. And we know that in any patients above the age of 40, if they come up with a lesion, we always have to think about metastases, myeloma, and in certain cases, chondrosarcoma, which is quite common in those age groups. When we talk of pelvic tumors, the commonest pelvic tumors in order of frequency are chondrosarcoma, osteosarcs, Ewing sarcomas, and soft tissue sarcomas. Pelvis is also the second commonest site for metastatic bone disease. Hematological malignancies are also not uncommon. And we all know that in the flat bones, the prognosis is not as good as when they are compared with the long bones. The commonest site for pelvic bone tumors are the iliac bone, followed by the ischial, iliopubic ramus, and the acetabular region. And there is a good classification which has divided these into 4 different types. And it is not infrequent to see one area of involvement overlapping into another one. The presentation is quite varied and it is usually very late, as we know that the pelvic brim and the pelvic cavity is quite large and accommodating, hence the tumors will increase to a significant size before they produce any symptoms. And that is why whenever we see these pelvic tumors, they are of a larger size. Sometimes they can present with pain, lump, occasionally with a fracture, and it is not uncommon to see these patients presenting to us with bowel, bladder, or neurological symptoms. So how do we work them up? We always stage them. So we do local staging and systemic staging. And once we've done that, we do a biopsy to confirm the histological diagnosis. And depending on the type of tumor, they may or may not need neoadjuvant treatment. Following that, we restage these tumors again. And depending on the response, we may either go to surgery or shift to second-line chemotherapy. And depending on the response of the tumor to any neoadjuvant treatment, that patient may or may not need further adjuvant chemo or radiotherapy. Any staging system is the commonest one that is used in musculoskeletal tumors. However, some people also use the AJCC, but we know that the AJCC involves lymph nodes and very rarely lymph nodes are involved in sarcomas. So in local staging, the first and foremost investigation that we always get is a plain radiograph. For soft tissue tumors, it is usually an ultrasound, but we will need cross-sectional imaging for local staging in the form of a CT scan and or an MRI scan. For systemic staging, we usually get a CT scan of the chest, and if we are concerned about a metastatic disease and we are looking for a primary, we also augment it with an abdomen and pelvis CT. A bone scan to look for any systemic disease. The role of PET scan is evolving, and it is recommended in systemic staging in a lot of studies now. However, in our country, because of the cost of this, we are using it sluggishly, but more so for difficult cases and for not very convincing recurrences. Blood tests and tumor markers of varying sorts are also used for our systemic staging. So what is the role of an orthopedic oncologist whenever we are confronted with a pelvic tumor? The orthopedic oncologist is a member of a multidisciplinary team, which is composed of medical and radiation oncologists, a musculoskeletal radiologist, who more often is an interventional radiologist, a musculoskeletal histopathology doctor, a plastic and microvascular surgeon are always an active part of the multidisciplinary team. You need dedicated theater support team, dedicated ward nurses, and a dedicated physiotherapy team. So plain film is always the key, and that is the first investigation that we always get to see. And this is from where we get most of the information regarding a bone tumor. And there are usually 7 questions which we need to ask ourselves whenever we are looking at a plain X-ray. Which part of the bone is involved? Where in the bone? What is the lesion doing to the bone? And what is the bone doing in response to that lesion? And is there a periosteal reaction? Is there an associated soft tissue mass? And what is the characteristic matrix? And if we answer all these questions, in about 70 to 80% of the cases, we are able to come up to a list of a differential diagnosis. We know, as we discussed, that this is the initial screening tool, but it is not as precise and as helpful in pelvic tumors, because we know that in pelvic x-rays, there is soft tissue overlap by the bowel and the gases in the gut as well, which will make it difficult for us sometimes to see the tumor itself. And unless there is any gross destruction by the tumor itself, we may not be able to appreciate that. So here there is a slight drawback of the plain radiographs in the pelvis. So for instance, if you look at this plain radiograph of a female patient who had pain in the left hip, you would not be able to appreciate anything grossly wrong. But if you look very closely, you might see some chondral calcification on there. And we went in and arranged for an MRI scan, and you see this large chondroid lesion, which we were then able to take out by performing a P3 resection, which was a chondrosarcoma. Now, sometimes the signs may be slightly less subtle. As you can see that in this X-ray, the arrow is pointing to a lytic lesion in an elderly patient in the iliac bone. And when we did a scan, we find that there is a large expansile lesion, and the biopsy confirmed this to be a secondary to a renal primary. Plain X-rays are also very helpful in follow-up planning. So in this patient, a couple of years ago, we performed a P1, P2 resection. And just recently, we found on the plain X-ray that this patient has a recurrence. So plain X-rays are the mainstay of our follow-up, unless clinically we suspect something which is not obvious on X-rays, in which case we need to resort to cross-sectional imaging. And here you can see all the aggressive features that one would expect to see with a bone tumor in the X-ray on the right side. Typical popcorn appearance, which is of chondrosarcoma involving the iliac bone, which is a very common site for these patients. Cross-sectional images show that this involves almost all of the gluteus, but does not go through the sciatic notch, hence making internal hemipelvectomy possible for us. So MRI scans are also very helpful for us in order to perform and plan surgical intervention. Here in this plain radiograph, you can see very typical appearances of an aggressive pelvic tumor in a skeletally immature patient, and this tumor on biopsy turned out to be a Ewing sarcoma. a skeletally mature elderly patient showing multiple blastic lesions in a male patient, very typical of prostatic metastatic disease. Now, sometimes, as we mentioned, that the signs on the x-rays will be very subtle. This was a patient who had been presenting to different doctors and then a urologist with urinary symptoms and has had a few x-rays with similar appearances, and every time the very obvious was brushed aside. But if you have a look now on the arrow, you see that the lower part of the sacrum is missing completely. And when we perform cross-sectional images, we found this large tumor, which was very typical in the location. And on biopsy, this was confirmed as a chordoma. And based on our surgical planning and on cross-sectional images, we were then able to take this out with the help of our colorectal surgeon with just a posterior approach. For soft tissue sarcomas, it is usually an ultrasound that the patient starts off with before they end up with an orthopedic oncology surgeon. And we invariably require an MRI scan to assess the extent of the tumor before we can plan any surgical intervention. In the more recent past, the role of dynamic MRI scan has been discussed, and in certain centers, I know it has been used, but certain places they have given it up. Its role has been helpful in differentiating tumor edema from the tumor itself, and this helps us in surgical planning. PET-CT is another diagnostic modality which is being used more commonly and more frequently now, and they help us in assessing whether the lesion is benign or malignant based on the SUV values, and we know that anything more than 4.5 is more often than not a malignant tumor. They are also helpful to assess the treatment response, cases of neoadjuvant treatment, and in post-operative tumor surveillance for recurrence in difficult access areas. So then we come to biopsy, and before we can give any definitive diagnosis to any patient, we need to have a histological diagnosis. And the only time we should perform and advise a biopsy is when all the staging studies are completed. And if you're ever in doubt, always get a biopsy, because you'll never be blamed for doing a biopsy. Who should do a biopsy? Ideally, it should be done in your local tumor center by the surgeon who will be doing the definitive surgery, in a center where there is a musculoskeletal pathologist, and a surgeon should do the biopsy in case it turns out to be a primary bone tumor, because we know that the biopsy tract will more often than not determine the approach to accessing that tumor itself. Particularly for pelvic tumors, we always advise using image guidance. And you may or may not need the help of interventional radiologist, as I'll show you in certain cases where we have sought out the help of our interventional radiology colleagues. So different types of biopsy. FNAC have very limited role in musculoskeletal tumors. Core needle biopsy has got very good yield in people who practice orthopedic oncology. There is still also a role of open biopsy, and there are two different types of open biopsy: incisional and excisional. Excisional biopsy is usually done for tumors which are smaller, usually less than 3 centimeters or of equal size. And incisional biopsy in cases where there are no expertise, or if you've had 1 or 2 instances where a core needle biopsy has not been able to yield a diagnosis. However, with incisional biopsy, the morbidity increases and the risk of contaminating the tissues also slightly increases. We recently looked at our 100 consecutive core needle biopsies, and in only 3% of the cases, we had to go back in and do a repeat biopsy. So it yields good results. Here, as you can see, that only with 1 stab incision, we are able to take a good core of bone from the ischial tuberosity, which is a difficult access area for a pelvic tumor. And you can see in the picture on the bottom right that we get a very good core of bone, and that's the beauty of a core needle biopsy, because you get normal tissue along with perilesional and lesional tissue. So you give the pathologist a whole spectrum of bone to look at. It's also prudent to discuss the principles of biopsy. With needle biopsy, most of these principles, to be honest, are negated. But nonetheless, if one is performing still an incisional biopsy, the incision should be in the line of the definitive incision of your surgery. There should be minimal violation of soft tissues and only violation of the compartment. No neurovascular involvement. Hemostasis should be meticulously secured. And if a drain is needed, it should be along the line of the incision. As a matter of principle, one must also send a sample for cultures and sensitivities whenever biopsying for a lesion, because we know that infection is a common tumor mimicker. And a biopsy should be performed ideally by the surgeon who will ultimately be performing the surgery. So what are the different modalities that you can use to do your biopsies? We might use just plain fluoroscopy for easier access areas around the pelvis, ultrasound guided biopsy for deep-seating soft tissue tumors, usually where they are close to the neurovascular structures, and CT guided biopsies can be performed by our interventional radiology colleagues in difficult access areas of the bone. So coming back to this plain radiograph, which I showed you earlier, of a 9-year-old boy who's been going around with pain for a long time. When we did a CT scan, you can see that the arrows are pointing towards a lesion with a very nicely looking nidus, and everyone gets excited, as so I did as well, thinking that this was an osteoid osteoma with typical sclerotic changes in the iliac bone. But when we looked at further sequences, we find that there is this soft tissue element with it, and some fluid around that area is pointed out by these arrows, which gives away that this may not be an osteoid osteoma, and instead this may be an infection. So in instances like these, this is where your interventional radiology colleagues come in handy and get you definitive tissue for diagnosis, both for histology and cultures, to help you with arriving at a definitive plan. Here in this instance, again, in the periacetabular region, a tumor which is deeply seated and slightly longer for a fluoroscopy, to be performed under a fluoroscopy, where your interventional radiology colleague will help you getting a tissue for diagnosis. Another such tumor where you're not entirely sure how far you are away from your sacral foramina and sacral nerves, and that's where our interventional radiology colleague becomes handy again. A typical chondrosarcoma, and the neurovascular bundle is in line of your biopsy, and this is where again our interventional radiology colleague will help us in getting a tissue sample to deduct the diagnosis of chondrosarcoma. And it is also with these cross-sectional imaging that allows us to be able to perform an extra-articular P2 type resection in this patient, leaving them with a hanging hip and performing an internal hemipelvectomy. So in summary, pelvic tumors often present late. We know because of the larger size of the pelvic cavity. More often than not, they are malignant. As a matter of principle, osteochondromas are usually left if they are asymptomatic on long bones, but around the pelvis, we tend to resect them because they might grow, and by the time they become malignant or they become symptomatic, it is too late. And it is just because of the size of the pelvic rim. Index of suspicion should be kept very high because of the variability of the symptoms that they present with. It is always advisable to discuss these in a multidisciplinary team because you need the advice and experience of different specialists. Before you do any intervention, including a biopsy, all staging studies should be performed. And if in doubt in deep, difficult areas, it is advisable to get a CT guided biopsy. Thank you very much.
Thank you, Dr. Zishan. I think we'll keep the questions at the end. Thank you, Dr. Zishan.
My pleasure.
And we move over to Ben. Ben will talk about challenges in margin-free pelvic resections.
Thanks, everyone. I'm glad to be a part of this. And it's good morning here in the United States, but good afternoon in Pakistan. So it's nice to see all of you, even though we won't be able to see each other in person anytime soon. We can do it over the computer. So I don't have any disclosures. I'm going to be talking about challenges with obtaining margins in pelvic sarcoma. So anytime we talk about a sarcoma, these are the goals, really. So we're trying oncologic control. We're trying to cure patients of cancer. we're trying to limit local recurrence, and we're trying to optimize function. And the goal of margins, or obtaining clear margins, really has an impact in all of these areas. I think it's most obvious with local recurrence. Clearly, if you don't get the tumor out, or if you don't get it out well, we'll have issues with the tumor growing back. But we also know in terms of survival that if we don't do a good procedure to remove the tumor, the chance of survival is diminished. And we know with functional optimization that the closer margins that we can get typically are better than function. But if our margins are too close and lead to local recurrence, then the function is also going to be compromised. This is an example of a situation of a pelvic tumor. So if you look at the MRI and the CT scans, this is looking like a chondrosarcoma. There's a chondroid matrix. This is a patient who presented with urinary retention. So he did not have any pain. This thing was probably growing slowly in there for years, if not decades, and turned out to be a low-grade chondrosarcoma. So when you look at this, there's a few things that you would think. Certainly the resection looks like it will be challenging. You can see it is displacing the bladder. It is next to the rectum. The ureters are in there somewhere. The main blood vessels of the extremity, the external iliac artery and vein, are in there somewhere. But one of the considerations that we would have in orthopedic surgeons is, what is the status of the hip joint, and are we going to be able to save the hip joint? And this is where you get into an issue with margins, and how wide do you need to be, and how close can you be if you're trying to save an important functional structure like the hip joint. So this is the question and the problem that arises when we take care of pelvic sarcomas. And the pelvis is different than the other areas that we take care of. So commonly tumors appear in the femur or the humerus or the tibia, and these structures we're more used to and are simpler to take care of. The pelvis is an area where the structures are larger. So we're not dealing with the femoral artery, we're dealing with the common iliac artery. They're more dangerous. If you lose control of the external iliac vein or the internal iliac vein, it can be quite dangerous. We're next to the bladder, we're next to the rectum, we're next to the ureters. There's less mobility with the dissection. This is one of the more frustrating things about pelvic surgery, that even once you make your third bone cut and there's no more osseous contact, the ligaments in there are so strong that the tumor is not able to be mobilized, and you're not able to see it any better. The visualization is difficult. The holes are deep. It's difficult to get lights in. It's difficult to get retractors in. And we are not in this area as much. And I think that that is a big limitation, that the femur tumors and the humerus tumors are just more common. I think we're all familiar with approaches to the knee and approaches to the hip, but approaches to the pelvis we just don't see as often. And this is really right at the edge of what we do as orthopedic surgeons. And once you start to get into the retroperitoneum, this is more the purview of general surgeons. The other issue with the pelvis is that the results are just not as good. Pelvis tumors don't do as well. And really in every facet of what our goals are, their survival is worse, the local recurrence rates are higher, and the function is worse. And all of this kind of leads into a very difficult time trying to remove pelvic tumors with appropriate margins. This is a couple examples of survival in pelvic tumors. So this is osteosarcoma and Ewing sarcoma. And really, when you just compare by location, the survival is quite different between the two. And now there's a number of things that could go into that, but if you just compare by site alone, clearly pelvic tumors don't do as well. Chondrosarcoma, the same. One thing to note is that about a quarter of chondrosarcomas will happen in the pelvis. So it's really not an uncommon sight to see when you're dealing with chondrosarcoma. The figures on the right side of the screen are kind of an interesting way to look at survival. So this is something called conditional survival. So we are all used to measuring survival in 5-year increments at the time of diagnosis. So if somebody comes in with a new diagnosis of osteosarcoma, we'd say, well, your 5-year survival is going to be 65% if it's non-metastatic. But the idea behind this is, well, what if they lived 3 years or 4 years or 5 years? Now what is their 5-year survival prediction? So that's what these graphs are. And you can see for a low-grade chondrosarcoma, which is at the top, pelvis and axial do about the same. For an intermediate grade at the bottom, the axial tumors start off with a diminished 5-year survival prediction of about 80% compared to 90% in the extremity, but eventually they come together 5 years out. But with the high-grade tumors, you can see while the extremity tumors, if you live 5 years, your 5-year survival rate is almost 100%. With the axial tumors, it's still down into 70%. So what I think you can ascertain by that is that there are more problems with axial tumors with recurrences, whether they be local or distant, and they're just harder tumors to manage inherently. Another thing that's important to discuss is just the definitions of margin and margin classifications. In our world, we run across two major types of classifications. So one is the Inniking margins and the other is the residual tumor classification. So the Inniking margins are histologic margins. So they're defined based upon what the final margins are under the microscope. Defined as intralesional, which is tumor at the margin somewhere. Marginal, which is a resection through a reactive zone. So not tumor, but also not quite normal tissue. So kind of a pseudocapsule or the reactive margin just around the tumor itself. A wide margin is a resection with a cuff of normal tissue, and then a radical margin is not done often these days, but is a compartmental resection. So radical margin for a distal femur tumor would be a complete resection of the femur, explaining why historically, before the days of chemotherapy and MRI, these were often treated with hip disarticulations. The residual tumor classification we should be familiar with. It is more common, a staging classification in the realm of surgical oncology, neurosurgery, and it's divided into macroscopic, microscopic, positive, and negative. The other thing I would point out is that there is some communication and overlap between the two, but the level of detail is different. So an Inniking margin, if we were to call it intralesional, that could be an R1 or R2 resection in the residual tumor classification. And similarly, an R0 classification could mean marginal, could be wide, could mean radical. So depending on what margin we use, the amount of detail and information you can glean from it is different. And this is, I make this point because it's an inherent limitation at trying to determine how good of a margin we need. And it's another plea for any time that we're making a report or a scientific presentation regarding a tumor resection, it's important to discuss what the margins are and what classification system we're using. In orthopedic oncology, the Inniking classification has some advantages. I find that even though it is a histologic margin, it's something that you can use for communication and preoperative planning. So as we're discussing these tumors, we can talk about our intention to obtain a wide margin or a marginal margin. And I think it's a good way where everybody kind of knows what the discussion is about. In terms of outcomes, so the local recurrence rate for all pelvic sarcomas taken together, this is a report from maybe a decade or so ago, and they reported a 45% 5-year local recurrence rate for pelvic sarcoma. So that's quite high, and I would compare that to osteosarcoma, where the local recurrence rate for an extremity osteosarcoma is typically less than 10%. So quite a bit more of an issue with local recurrence in pelvis tumors. And they reported that the relative risk was over 5 times more if a wide margin was not obtained. So anything less than a wide margin had an increased risk of local recurrence. Osteosarcoma, in a report out of the Birmingham group in England, reported 30% local recurrence. And they too identified that a less than wide margin had a higher rate of local recurrence. So 44% with an intralesional margin versus 17% with wide. So it makes sense that an intralesional margin would have a higher local recurrence rate than a wide margin. The other thing I'd point out about this, though, is that a nearly 20% recurrence rate with a wide margin is an enormous local recurrence rate for what was thought to be an adequate margin. I'm sure, good plan and good execution. So again, a reminder that these tumors are difficult. And finally, chondrosarcoma, the same, nearly 40% local recurrence. And the hazard ratio was over 3, comparing marginal or intralesional to wide resections. What's being talked about in pelvic tumors more often nowadays is computer assistance. And so this can be done either with intraoperative navigation, or it can be done with custom cutting guides. Custom cutting guides is the technique that I've used when I've done this. The way I think about custom cutting guides is it's basically the way to do intraoperative navigation without a intraoperative computer system. So you just happen to be navigating prior to the resection, and then you've made your plan prior to the resection. People are becoming increasingly excited about these opportunities to use navigation and to use cutting guides. I would say that it's maybe not in its infancy, but it's still in its childhood. And we're still learning a lot of things about this. There are some compelling reasons to be excited about intraoperative navigation and cutting guides. The anatomy of the pelvis is quite difficult. It's hard to figure out where you are. It's hard to know what angles you're at. You need very wide exposures for these things. But the thing to remember about the navigation and cutting guides is it doesn't help you with the soft tissue margin. So it may define where your bone cuts are, but it's still up to you as a human being to figure out where to make the cuts for the soft tissue margin. And for the most part, when there are local recurrences here, the soft tissue margin is likely the source more often than the bony margin. The other issue when you're trying to put these custom cutting guides on is you need a lot of exposure to the bone. You can see in this picture in the upper right-hand corner. You can imagine to be able to place this cutting guide and to make sure it's in the right place, you need to essentially expose the entire ilium, even though you're not cutting the ilium out. And the other concern that you would have with these is the necessity of placing these cutting guides may require you to be closer to the tumor with your soft tissue dissection. So I think that this line of research and investigation is important. I think there's some clear benefits to it, but I don't think we've sorted it quite out yet. And it's always this tension between better margins and better function. So the further away we are from a tumor, the better it's going to be, but the further away we are, perhaps we're limiting some of our reconstructive options, or we're impacting the resection in such a way that it's going to limit function. So this has been the challenge with pelvic tumors and really all sarcoma. And that's really what informs this idea of computer assistance, with the goal of narrowing margins as much as possible. But obviously we don't want to narrow them so much that we're causing an issue with local recurrence or oncologic problems. This is a Birmingham group. Again, they've written a lot on pelvic sarcomas. Their early reports with intraoperative navigation showed a 35% local recurrence rate, so really no advantage over the other techniques. They stated that all their bone margins were clear, and so the local recurrence had to be coming from the soft tissue margins. And what they recommended in this, and this is based not upon this research alone, but on looking at their other studies, is that osteosarcoma should have 2 millimeters of a margin. Chondrosarcoma should have a little bit larger, 4 millimeters of a margin. And their recommendation is you should preserve life first. So don't compromise your margins based upon the goal of obtaining better function. Take the tumor out first. And I would comment that these margins, 2 millimeters and 4 millimeters, they seem like they would be a small distance. And for the bone cuts, I don't think it's that difficult. But as you're trying to obtain soft tissue margins, this can actually be quite difficult. So 4 millimeters is quite a bit. That may mean an additional muscle on top of the tumor. So not only do you take out the gluteus minimus, maybe you take out the gluteus medius to be able to get 4 millimeters of a margin. And it's not uncommon that the overlying tissue will slip or that your visualization will be bad. So this is actually quite a challenge to get 4 millimeters of a margin anywhere. But I think the implication there is the wider you get, and specifically the wider you get with normal covering muscle tissue, the better your margins are likely to be. Here's a couple examples of cases that we've done. So this was a very strange and aggressive presentation of a malignant peripheral nerve sheath tumor occurring in the pelvis. This was a very aggressive tumor. We tried neoadjuvant chemotherapy and radiation, and actually grew through those interventions. The patient developed metastatic disease, and so we felt a definitive procedure with minimal complications was warranted. You can see how much this is impacting the structures, the retroperitoneal structures, displacing the bladder and rectum. And what we elected to do was an external hemipelvectomy, primarily to obtain better margins. Given that the posterior margin was, I was concerned that it was contaminated with the previous biopsy, we elected to do an anterior flap hemipelvectomy using the quadricep mechanism on the superficial femoral as a perforator. So this is a nice flap to use. It's nice and healthy. For this patient, this was the right decision to get the tumor out and be able to continue with systemic treatment. This is a patient, an older gentleman who presented with a grade 2 of 3 chondrosarcoma with a pathologic fracture. One thing now that I would mention about chondrosarcoma, there is a significant likelihood of the chondrosarcoma being upstaged on the final diagnosis. So this is where the recommendation comes from. Zishan mentioned it a bit, is that you kind of have to treat chondrosarcoma a little bit differently. And part of the issue is, even if you get a biopsy and it shows a low-grade chondrosarcoma, it's quite possible that on the definitive resection, it will be an intermediate or high-grade tumor. So with chondrosarcoma, no matter what you see on the biopsy, I think you always, in your mind, you have to think that it's perhaps going to be a bit more aggressive than you would think. The other issue, of course, with chondrosarcoma is we don't have the adjuvants that we have for other treatment. We don't have chemotherapy that works. Radiation treatment is not a mainstay. So this is the other issue. While perhaps a chondrosarcoma margin needs to be bigger than an osteosarcoma margin, and surgeries are only good intervention. So he presented with a pathologic fracture. He had some edema in the muscle. I did use custom cutting guides for this, and you can see using CT scan with the help of MRI a bit, just to know where the tumor is. We planned 1 centimeter margins surrounding this. This would be a type 2 resection of the acetabulum. We executed the plan the way that we wanted to, and I had the ability to have a custom prosthesis made. The margins were negative. Our closest soft tissue margin was 1 millimeter, which is kind of that marginal margin, just a covering of the fascia over the top of it, due primarily to the size of the soft tissue mass. And remember that your margin is your worst margin. So we were further away from the tumor in a number of places, but we were closest to 1 millimeter, so that's our margin. And the closest bone margin was 2 millimeters, which to me was negative, but was concerning because I had templated for a 1 centimeter margin. So there was clearly some microscopic extension within the intramedullary canal. And unfortunately, this patient has not done very well. He had lung metastases 9 months after surgery. And then about a year after surgery, he had some increasing pain. An investigation revealed a large local recurrence, both in the residual ileum, but also extending halfway across the sacrum to a place that is basically unresectable. And now he's on palliative chemotherapy and pain control. So my recommendations for optimizing margins. So I think the most important thing that we can do is preoperative planning. I tend to plan my bone cuts to be greater than 1 centimeter unless there's a real clear benefit. So when you get to a place where perhaps you're around the hip joint, can I save the hip joint? This is where maybe you're talking about taking a little bit less, or you're trying to use a prosthesis, and so you want to save some posterior ilium in order to build a prosthesis off of. But if you don't have to be closer than 1 centimeter, I would not recommend being closer than 1 centimeter. The pelvis bone, it's a flat bone. It's hard to tell the extension into the bone, even with good MRI scans and good preoperative planning. I've had microscopic positive margins thinking that the tumor had stopped, and now here it comes extending past our level of resection. So I would actually go even more than the Birmingham recommendations and say stay at least 1 centimeter away unless there's a real clear benefit. If there's involvement in the retroperitoneal structures, get general surgery involved, urology involved. If you need to put stents in the ureters, do it. Think about intra-articular extension. So is the hip joint involved? Around the knee, it's rarely involved. I find that the hip joint is involved a bit more commonly for these pelvic fractures, and it's actually not terribly difficult to extend this into an extra-articular resection rather than an intra-articular resection. So you want to look for any fractures through the acetabulum, any joint effusions, any nodularity, and then really preparing your anatomy. And one of the benefits of doing navigated surgery or custom cutting guides is it forces you to sit down and think about what your resection is. And you could argue that's the most important part of navigating is preoperative planning. I have a pelvis model. I think a lot of you probably do as well. I like to draw where my cuts are. I like to visualize. I like to take it up to the operating room and have it with me if I need to look, because the anatomy is confusing. And then the surgery is difficult. Think about the execution, your exposure, lighting, what bed are you using, how is the patient positioned. make sure the anesthesiologist has control of the patient in terms of arterial lines, central lines if needed, that blood is available. These are big tumors. These are the biggest procedures that you can do to the human body. It's incredible that we can get people through these, but we need to be prepared for them. And then in general, the iliacus can remain as a deep margin on the inner table. The abductor minimus can have the same role on the outer table if needed. That gets a little harder to deal with the superior gluteal arteries and nerves. Sometimes they're involved and coursing through the abductors, and can be a challenge to keep those, and more often than not need to be sacrificed if there's any tumor in the area. The bottom line is that these are difficult procedures. They're hard. They're going to stay hard. Preparing as much as you can is the right thing to do, certainly. But these are a challenge now, and I think they'll remain a challenge well into the future. Okay, thank you.
Okay, thank you, Dr. Ben. Very enlightening indeed. So from biopsy techniques to margin clear surgery, we will now move on to challenges and reconstructive options by General Sohail Hafiz. And as I said, we'll take questions at the end, and I am also getting some online questions, so we'll try to handle the questions at the end and see how much time we have. So let's finish with the presentations first. Over to General Sohail Hafiz now.
Thank you very much, Masood. As I was talking to Zishan, that every time you step onto the podium, you have to figure out how to take the slide forward and backwards and everything. So thank you very much, Masood, for asking me to speak on one of the topics, difficult topics. I would like to say hi to Franklin Sim, Mayo Clinic, and once I see his ambience, that reminds me of my visits there. Ben, thank you very much for joining us. My talk is on challenges of reconstruction after pelvic tumor resection. My old place, CMS Rawalpindi, and my present place and bottom, that is Shifa International Hospital, Islamabad. Okay, if we look at it, how to reconstruct, most of the time, most of the orthopedic surgeons are thinking from only a purely skeletal reconstruction point of view. But in my opinion, it is not only the skeletal reconstruction which has to be considered, but also the soft tissue reconstruction. Amongst the skeletal reconstruction, I think the most important factor is the weight transmission. If we understand that the weight is transmitted from the hip joint along the iliopectineal line to the sacrum, or it can be transmitted across the pubic symphysis to the opposite SI joint. So the most important fact in the reconstruction is the interval between the hip joint and the sacrum. If we don't have that weight transmission, then we'll have to figure out how to reconstruct that kind of a strut by which we can transmit this weight. The other principle would, of course, be to maintain the limb length after the surgery. And then, of course, if we have resected the hip, how to reconstruct the hip. Coming to the soft tissue reconstruction, some of the surgeons would watch me out that since it's a major surgery, the incision is quite significant. And if you have taken out the superior gluteal or inferior gluteal vessels as well, so the wound dehiscence chances are there. So one has to be careful about how the wound is going to behave afterwards. And if you have doubts, I think our plastic surgeon would be there to help you. Another thing one must understand is that the skeletal, that the ilium, pubis, and the ischium also act as a boundary or as a block to the viscera, that is the intestine, the bladder, and all those things, that they don't let it herniate. But imagine if you have done a type 1, 2, or 3 resection, then there is nothing to hold the visceral structures inside, and the chances of herniation are there. And another important thing is that if you have taken incision circumferentially almost around the groin, then you have disrupted all the lymphatics which are going from the lower limb up into the abdomen. So you may end up in having a very fat limb, and one has to consider this problem as well. I'll just touch the soft tissue reconstruction first, and then in the rest of my talk would be on the skeletal reconstruction. In the soft tissue reconstruction, if we have any doubt about the viability of the flaps, or if you have doubts about the lymphatic flow, then probably a plastic surgeon would be there to help you in the form of having either a local rotation flap, in this case, a tram, or maybe a distant free flap, a lat or a ATLF flap would be helpful. The second problem that I pointed out was the visceral herniation. So one has to be ready to use or request your general surgeons to produce a boundary between your reconstruction and the thigh as well. So a muslin mesh might be helpful to stop the viscera inside the pelvic cavity. Now let's come to the skeletal reconstruction itself, the options which are there. As I pointed out earlier, that the key is the weight transmission from the head of the femur to the SI joint. So depending upon the type of resection, you may not need any reconstruction. For example, if you have got a P3 resection, that is, you are removing the ischium and the pubic rami. Similarly, if you're doing a partial P1 resection in which a bar of bone is available between the acetabulum and the SI joint, you may not need any reconstruction. But if it's a complete P1 resection, then you would have to do some kind of a reconstruction there. The main problem is if you do a P2 or a combination of P2 with a P1, or if you have done a P1, 2, 3 resection, then of course you will have to do different kind of reconstructions and some of the options available that we are going to talk about. Another factor that you have to consider if you have sacrificed the hip or not, and that would also figure out how to reconstruct the hip. Now, starting off, as I said, that you may not require a reconstruction as it is shown in the P3 resection on your left, or if you have got a partial P1 resection, that is, if you have got you have resected the ileum only partially and you still have a bar of bone, say, between the head of the femur, the acetabulum, and the SI joint as shown in these. Now, just a workflow that what are the different options available for us for the reconstruction. It could either be a biological, prosthetic, or a combination. We also have to consider the environment that we are working in. Of course, in Pakistan, we may not have the luxury of having custom designed prostheses, so one has to figure out how to reconstruct these P1s, P2, and resections. So the options available, the biological options available to us are, number one, we can leave them alone, no reconstruction at all. We can use an allograft, which we don't have the luxury of, or we can do an arthrodesis in the form of an iliofemoral or ischiofemoral arthrodesis, or we can use some kind of strut which is available to us. And some of you who know me well, I'm quite fond of free vascularized fibula, and I've used it in some of my cases. You can also use a non-vascularized graft, and there is some talk about the recycled autograft by pasteurization or liquid nitrogen use. The prosthesis that we have got could either be custom made or off the shelf. I'm going to talk about them, or now the latest, of course, is the 3D printing options available for that particular patient. Of course, the combination would be the allograft prosthesis composites. So I'll pick all of them one by one, and we'll discuss their pros and cons. So amongst the biological reconstruction, the first thing, of course, is you do a resection and leave it alone. I'm grateful to Masood Umar for providing this slide of one of his patients. This is a P1, P2 resection, and of course the plus H as well, the head has been taken off. One can think of this resection, it is quite reasonable an option. It has its advantages, which include that you don't actually require a complex reconstruction later on. You can mobilize the patient fairly early, it's durable, and the patient does not have really very severe pain after it. But and it has less complication. But the negative aspect is that the patient would always require support to walk around in the form of a walking frame or 2 crutches. And of course, the limb would telescope proximally, and this will lead on to a very short limb as well. The other option, biological option, is do either a iliofemoral or ischiofemoral arthrodesis. A very reasonable option in our circumstances if one can manage, if one can achieve this arthrodesis. Mind you, this is a difficult arthrodesis to achieve. The pluses of this would be that in a young patient, and if, as Ben said, if he survives 5 years, he can live with this forever. It is a permanent situation and a stable limb, but the disadvantages are that it is very difficult, as I already said, it's difficult to achieve an arthrodesis. Limb shortening is possible because if you have to take the femur up to the ilium, you would have some shortening. And if you have done an ischiofemoral arthrodesis, then the weight would be transmitted across the pubic rami, and this may lead on to a painful symphysis pubis later on. My workhorse, I looked at my pictures and I used this free vascularized fibula as a strut in P1 resections and also as an arthrodesis for iliofemoral arthrodesis. Here we are on your left, of course, is if you see we have done a P1 resection in which we were able to save the acetabulum. And then we had a vascularized fibula, and then we used this recon plate, 3.5 millimeter recon plate, and to the sacrum. If you look at the opposite, on the right side, then you see I've used a double barrel fibula, and I've used a recon plate to give it some support. If you look at the iliofemoral arthrodesis, if you look on the picture on the right side, this is, I think, about a year or two later. And if you look at the proximal part of it, you see a lot of exuberant callus form, and this has actually fused quite significantly. But the other bit, of course, you see that I've put in a vascularized fibula starting from the pubic bone up to the ilium. So, and which is, of course, protected by this recon plate going to the opposite superior pubic ramus. This was a case of chondrosarcoma, and he's still living, walking around with the help of a stick. Now, if you look at this particular picture, of course, I had to have a shortening because if I wanted to take the femur up. In another case of mine, after learning from this, what I did was, after doing a P1, P2, and P3 resection, I got a double barrel fibula, a vascularized fibula, hitched it between the ilium and the head of the femur, and here I was able to maintain the limb length as well. I'm not advocating the use of vascularized fibula in every patient, but what I am saying is it is one of a good viable option in selected cases. It has its advantages, which includes maintaining limb length if you're careful, weight transmission if you get a solid arthrodesis, but it has its negatives as well, which means that you need to have a good plastic surgeon. And those who know me, my friend Mamoon is always with me, and we can spend a lot of hours in the operation theater because this kind of surgery, the excision itself takes a long time, and then reconstruction would also take much longer time. The other problem is that if you are put in a strut, a vascularized fibula in between, then you would have to have two places where you would like to have a union, proximal and distal, and you may not be successful in all the cases. The chances of infection because of the prolonged operative time would be there. Now, I went into the literature and I was looking at the reports of using the host bone, taking the resected sample, removing all the soft tissue and pasteurizing it or putting it in a liquid nitrogen. Most of the series were from the East, coming from the Korea, China, and Japan. But in one of the analysis, it was found that they were very late in incorporation. In fact, they behave more like an allograft, and they have a much higher complication rate. I'm afraid I have absolutely no experience about using the autograft of the native bone. Now, coming to the prosthetic reconstruction, what are the different options available? If the disease is in a very small area of the, for example, the acetabulum, for example, a metastatic disease, and you are confident that you can resect that small part of the acetabulum, then you can, of course, reconstruct it by the help of using the head of the femur as a graft, and then you can use the dentulum or jumbo cups, and you can use a regular total hip replacement. But these are very few cases in which this option would be available. Historically speaking, we had this saddle prosthesis. I'm thankful to Franklin Sim. This is his, these are his slides. They were the initial prosthesis used, but they had major complications. The pluses of this the saddle prosthesis, it's a very simple reconstruction, relatively simple reconstruction. One can start immediate weight bearing and a reasonable stability is achieved. But the negatives are you actually have a non-anatomic high hip center, and therefore a lot of pressure is coming on it. And the saddle ultimately goes on migrating proximally, or it may even fracture the ilium and lead on to an instability. I'm not sure whether this prosthesis is now being used in any center. My understanding is that it probably has been given up. The other option available, of course, is this what we call a cup and cone prosthesis. Duncan Whitwell has made us wiser. He has a large, not a very large, few cases of this. This is like a cone. The acetabular component is attached to a cone, which is fixed into between the two wings of the ilium, medial and lateral. And then, of course, they have a problem of incorporation. So Duncan came with a clever trick in which you use the tantalum buttresses, which are put both on the medial and the lateral aspect of the iliac wing. So they would probably help to incorporate this prosthesis. This one particular is, of course, a motor prosthesis. There are many other prostheses available by different companies in which you can actually kind of dial in the acetabulum and use a normal total hip, that is the femoral component on the opposite side. It has its pluses and it has its negatives. The pluses are, of course, you don't really need any custom design prosthesis. You can take it off the shelf. By using the tantalum, you can increase the chances of its incorporation. But the minuses are, it has a higher rate of dislocation. So you have to be very, very careful how you place the cup, the version of the cup versus the version of the femoral neck. For our country, of course, it's quite an expensive undertaking. It takes about 12 to 15 lakh rupees. The chances of aseptic loosening, we haven't reached that point where we can say the long-term results of these prostheses. We'll have to wait 5 to 10 or 15 years to say that if the patient survives this disease. The latest trend, of course, is the 3D printing and personalized prosthesis. A lot of work is being done in the East and West. Of course, you need an MR and CT scan. You actually plan the section based on this. You create a model, and then you can use porous metals to produce a prosthesis. The very, very fine way of doing it, very neat way of getting out. Different options available. The pluses are, of course, you can do an immediate reconstruction. You need an exact resection, and you can match it on table as well. And you can, if your software has actually picked up the MRI properly and you have been able to navigate properly intraoperatively, you can get an oncological clearance as well. And this metal, of course, which is porous, also gives you place for anchoring your ligaments or the muscles. The negatives, of course, are you have to be actually absolutely precise in doing the resection because if your resection increases from whatever you have decided preoperatively, then your prosthesis would not fit in. The equipment, of course, is very expensive. It requires a lot of investment in the first go, and implant would ultimately also be more expensive. Designing and printing procedure also take time. It takes about 2 to 3 weeks before you can take the patient to the theater, and it requires training and manufacturing of this prosthesis. Again, we can't say anything about the loosening till we cross the 5 to 10 years line, whether the aseptic loosening occurs or not. Again, thankful to Professor Franklin Sim for these slides. These are the allograft prosthesis composites in which after resection of the tumor, You take an allograft, match it, trim it, and then fix the allograft to the host remaining bone with the alpha multiple plates, and then you can put in a ordinary total hip replacement. The pluses, of course, are you can do an immediate reconstruction, you can fill in massive defects, and you can start early weight bearing. The negatives, of course, is that the allograft takes a long, long time, and in some of the cities, they are not incorporated at all. Aseptic loosening is there. The chances of putting in a massive bone graft, it may invite infection. And then the most importantly, that you have to have the bone bank, which we don't have the luxury of. And of course, it's an expensive, allograft are quite expensive, even by US standards. So I would like to sum up by saying that the pelvic tumors are not that common. Even in a center which is doing regularly the ortho-oncology, the number of resectable pelvic tumors is much less. Therefore, very few surgeons have an experience in handling them. It's a complex surgery, as Ben has already pointed out. You have to be sure that you are able to achieve both skeletal and soft tissue margins. And then, of course, after you have resected it, you have to consider both skeletal and soft tissue reconstruction. And I'm blessed to have a very good team of a plastic surgeon. You may need a general surgeon, a urologist, or a vascular surgeon. In case of a P3 and a P1 partial resection, you don't need to do a reconstruction at all. But in other reconstruction, other resection, you have the option of either biological or a prosthetic or a combination thereof. In the end, I would like to say that we need to establish a few referral centers in the country where the surgeons who have sufficient experience to handle these patients should be operating upon this. I would say it should not be taken up lightly. It's a complex surgery. And I think 4 or 5 centers in the country would be good enough to handle all kinds of pelvic tumors. The audience, which is here, quite a significant audience, 116 I counted last. I think if they get this message to be able to diagnose them, pick them early, diagnose them early, and then refer them to the right centers, it will be beneficial both to the patient and to the surgeon. This benefit to the patient because he would be treated by a person who has more experience, and the surgeon will be getting more and more experience so that he handles the next patient in a better way. I think that was all about my talk. If there are comments, I think Masood has said that we'll take the comments and questions in the end. Is that so?
Gee, thank you, sir. Excellent talk, right from biological to prosthetics. We move on to Dr. Franklin Sim, who is my mentor also in orthopedic oncology. And I was lucky to spend some time with him at Mayo Clinic, as was Dr. Suhail Hafiz. Dr. Sim has been a mentor of many surgeons across USA and across the world, and we were privileged to have him here in Pakistan on multiple occasions, and we have a very good, still have a very good relation with him, and would like him to come down sometime again for our national meetings. Today he's going to talk about new paradigms in sacral tumors, kind of moving away from the P1, P2, P3 resections over to sacral resections, and Dr. Sim has something very useful and almost 50 years of experience behind him to take us through this very difficult topic. Over to you, Dr. Sim.
Thank you very much. It's really a pleasure to participate in this with you, Dr. Umar. It's nice to see everybody here today. I look forward to when we can visit Pakistan again. I know we've certainly enjoyed some good times there, and look forward to hosting you in Rochester. So sacropelvic tumors are among the most challenging problems we face in musculoskeletal oncology, historically with poor results following a treatment. Okay, I think we're in control now. There are many challenges, but the biggest challenge, I think, is from the anatomical complexity of this area and how difficult it is to achieve adequate margins for local control with the viscera and neurovascular structures. And has been pointed out, these require a multidisciplinary team. However, as talked about earlier, there has been significant advances in diagnosis and staging to determine the proximal extent of involvement. And of course, this is going to imply the degree of neurological sacrifice, and the extraosseous extension, which will show the pelvic organ involvement and need for flaps. Here you can see the sagittal MRI shows the extent of proximally tumor very clearly going into the S1 sacral vertebrae. And the axial MRI shows a soft tissue extension, the visceral and iliac involvement. One of the more important views is this coronal oblique image, because it shows a relationship with the tumor to the foramen. And here there's involvement of the S3 neural foramen. Sophisticated contrast CT protocols using angiogram, phenogram, and urogram help delineate the relationship to these important structures. So one of the adverse factors has led to poor results in the past, and this has already been pointed out, is an adverse biopsy, which can contaminate multiple tissue planes. So very important in these tumors is to carefully plan the biopsy to minimize contamination, and where it can be completely excised at the time of surgery. Here's two examples of poorly executed biopsies. You can see tumor coming through the incision and seeding of the perirectal space. So obviously this precludes a successful outcome with surgery. So historically, the problem has been the high local failure rate, which has adversely affected the outcome. And this has been discussed by other speakers. There's usually a delay in diagnosis because the symptoms are insidious and variable and confused with other conditions. So the tumors reach large volume, they're not well marginated, and as we mentioned, a relatively inaccessible location. However, studies from various institutions have recently shown a dramatic improvement in local control with more aggressive en-bloc resections to predictably achieve adequate margins. And these studies from Mayo, Memorial, and Rizzoli. So as a result, in recent years, there's been development of more aggressive surgical procedures to achieve predictable margins. It can be high through the upper sacrum, above the tumor, or radical sacrectomy, including the entire sacrum, wing of the ilium, portions of the lower lumbar spine, depending on the extent of the tumor. We also like 3D printed models in these complex cases, because with sophisticated resection, we can plan our surgery and determine the relationship between the tumor and the surrounding structures. These extended sacropelvic resections have a number of concerns. They're clearly technically challenging and associate with high morbidity, which usually relates to the degree of neurological sacrifice or stability. Now, Professor Gunterberg outlined these initially back in the 70s and further documented by the Mayo Group more recently. May require concurrent organ resection to achieve clear margins if there's direct visceral involvement, rectum, ureters, or pelvic organ devitalization. It may require, in addition to the surgical resection, a hemipelvectomy amputation. And these are usually very large tumors that are involved with the lumbosacral plexus, perhaps a femoral nerve, extend into the ipsilateral hip joint, and may have such a massive soft tissue defect following resection that they require flaps from the amputated leg. So one of the controversies is whether to do one or two approaches. Our philosophy has been, for lesions involving S3 or below, we'll do a single posterior approach. But for lesions S2 and above, we'll do combined anterior and posterior approach to maximize safety and obtain flaps to help with the posterior closure. So when the posterior only incision is used, no reconstruction is required in these patients, and we usually use local flaps, so gluteal flaps and mesh. When we do a combined approach, the anterior approach is done first. This allows visceral mobilization, devascularization of the pelvis. We'll do the preliminary anterior sacral and iliac osteotomies, and as mentioned, harvest the vertical rectus flap. So when we do the posterior, the combined approach, the posterior part of it is done usually 2 days later. We stage these for a tumor removal at that point, insert the flap, and a reconstruction can be carried out then. But if it's a complicated reconstruction, such as vascularized fibular grafts, we may delay that for a third stage. So we learned our lesson. Initially, we used to, I think, Masood, when you were here, we were doing these in one single marathon session that would require 16 or 18 hours. So when Dr. Rose joined our staff, he wanted to get home at night to put his kids to bed. So we decided to start to stage these. And then we did a study where we compared the single marathon session to the stage procedures, and the stage procedures did much better. They were in the ICU less duration, less days in the ventilator, fewer transfusions, and overall less general morbidity. And when we analyzed the cost, we were able to save almost $90,000 on the staged procedures. So this is our current approach. As we started to broaden our surgical procedures to achieve predictable wide margins, we realized there was no standardized system classification. There were some attempts in the literature, but there was no real classification of these aggressive sacropelvic resections. And the literature actually lacked any significant information in the surgical outcomes. So we sought to develop a classification of these sacropelvic resections where we could communicate among the various disciplines involved in these resections and predict the type of surgical approach for each type, the bony reconstruction, soft tissue reconstruction, as well as assess or predict the neurological and ambulatory function, as well as presenting the oncological results for each type. So all the patients in this group that we reported surgery was carried out for potential cure over this period of time. There were 196 patients, and you can see the majority were males. The mean age was around 50. The average follow-up was 7 years. Pathologically, 72% were primary sarcomas, and those additional 25% that were aggressive or recurrent visceral tumors, such as colon rectal tumors invading the sacrum. So the classification was based on the extent of resection as type 1 and 2, which are total and partial resections, and the need for an associated hemipelvectomy amputation as shown in type 3 and type 4. So this is a 1A resection, which is a total sacrectomy, includes the entire sacrum, portions of the lower lumbar spine, wing of the ilium, depending on the extent. And this implies a transperitoneal approach. The bony reconstruction is shown there. Is basically the posterior rod screw construct with the fibular grafts, which are often vascularized, extending from the lower lumbar spine anteriorly, the anterior pelvis. And this is done to restore the anterior sacral arch. And our studies show that it provides twice the resistance to failure as the posterior construct alone. Soft tissue reconstruction uses a vertical rectus flap. And neurologically, they're going to have loss of bowel bladder and sexual function. Ambulation is possible if we're able to preserve L5 nerve roots bilaterally. So there were 20 in this group, total sacrectomies, 9 males, 11 females, average age 50. They were all primary sarcomas, and the level of resection, the commonest level of resection was L5. So this shows a patient with a chordoma involving the entire sacrum. So he had a total sacrectomy, reconstructed with this cathedral method. And here you can see the dual rod constructs to provide improved strength and the fibula grafts. This was staged, so you can see the in the middle the vertical rectus flap, which is reflected. And 1 year solid fusion. I show this case to show the reconstruction can be varied and modified depending on the extent of the resection. In this case, it included L4, a large part of the posterior column of the hip joints. So type 1B resection is a near total sacrectomy. This is through the sacral foramen or above. And there are 3 studies in different institutions. There's one from Mayo that shows that the remaining bone in these high resections is inadequate to withstand normal weight-bearing loads, and they're subject for rotatory fractures of the remaining segment. So this implies a transperitoneal approach. We use bilateral fibula grafts, ram flap, and they're going to lose bowel, bladder, and sexual function, and they may have a possible sciatic nerve deficit, depending on the extent. So in this group, there were 3 males. Average age is older. There were three sarcomas and 2 recurrent rectal cancers, and the level of resection through or above the foramen. So a 1C is a pretty standard sacrectomy involving S1 and below. And here in our series, 2/3 of the patients had a posterior approach only. And in the ones that have posterior approach, of course, no reconstruction is necessary in this group, but require a mesh and local flaps. They're going to lose bowel, bladder, and sexual function depending on the level of the resection, but ambulatory function should be normal. So in this group, there were 104 cases. The average age is older. You see 60 were sarcomas and 44 were recurrent visceral cancers. And the level of resection was generally pretty equal between S2, S3, and S4. Now, type 2 resection is a hemisacrectomy, and this involves portion of the wing of the ilium, sacroiliac joint, and portion of the lower lumbar spine, depending on the extent of the tumor. This will imply a retroperitoneal approach, since it's unilateral. And the reconstruction is a posterior rod screw construct with a unilateral vascularized fibula graft. The ram flap is used for coverage. And neurologically, since it's unilateral, they're going to maintain bowel, bladder, and sexual function. And they may have a unilateral sciatic nerve deficit. So in this group, there were 29 patients. Males predominated. They're younger patients. And they're all, 25 of them were primary sarcomas. And the confidence level resection was L5 or S1. So here's a patient, a young patient with an osteosarcoma that had a type 2 resection with this construct reconstruction. And in this group, many will have require a partial sacrifice of the lumbosacral plexus. So our routine now is to do a nerve graft reconstruction utilizing sural nerve grafts. And this has been very promising. Here's this patient at a year. He's already wrestling. You can see the incision in his leg, and he's been snowboarding, much to our chagrin. And he sent me a photograph a year later showing his dorsiflexion of his foot had recovered. Type 3 resection is a hemisacrectomy in a patient that also required a hemipelvectomy amputation. As mentioned, these are generally large tumors, involve lumbosacral plexus or femoral nerve, and extend into the hip joint. So these patients, the approach is retroperitoneal. A reconstruction will be carried out if we sacrifice more than 50% of the lumbosacral junction. And since they have an amputation, we use a long anterior thigh flap for coverage. And usually this is extended into the distal limb where we can also harvest a vascularized fibular graft along with the flap. And they're going to ambulate as a hemipelvectomy amputee. Of course, they'll maintain bowel, bladder, and sexual function since it's unilateral. So there were 32 patients in this group, mostly males, younger patients. 28 of those were primary sarcomas. And the tumors in this group were very large. The level of resection was common up to L5 and 15. Here's a patient that required a type 3 resection, very, very extensive lesion. And this was reconstructed with the rod screw construct and the vascularized fibular graft, which had been harvested in the first stage with the long anterior thigh flap. Now, a type 4 resection is a total sacrectomy that also required a hemipelvectomy amputation. And you can see that this is going to require a transperitoneal approach. In these extensive defects, we use the femur from the amputated leg as an intercalated graft to bridge that defect between the remaining spine and pelvis. Soft tissue reconstruction is with the anterior thigh flap. They're going to lose bowel, bladder, sexual function, and they ambulate as a hemipelvectomy amputee. So there were 5 patients in that group, 4 females, again, younger patients. They were all primary sarcomas with large tumors. And one extended L3, but 3 were at L4. This shows a patient that had a type 4 resection and shows the reconstruction with the intercalary graft. So here you can see the proximal femur is brought up as an intercalary graft between the spine and remaining pelvis. The pelvis is medialized and externally rotated to maintain the center of gravity. And this is what the reconstruction looks like. This young woman that here she is a year following this reconstruction and riding her snowmobile. And here she is at 3 years. She's walking down the aisle. She's in a prosthesis, specially fitted prosthesis, using her cane to renew her wedding vows. Her 2 children are behind her. And here she is recently back for her 10-year anniversary and disease-free. Now, our group has done the type 5 resection. This is a drastic procedure. We've done this only a handful of times. There's one patient in this group. This is going to imply a transperitoneal approach, and there's, of course, no bony reconstruction. The difficulty is achieving soft tissue reconstruction, trying to plan flaps to provide coverage and leave room for the abdominal contents. So they're going to lose bowel, bladder, and sexual function, and they get around pretty well in a bucket orthosis, custom fit. So here's the patient in this series. He had a hemicorpectomy for a very large recurrent chondrosarcoma in his pelvis, and he's now 10 years and remains free of disease. Here's a recent patient with a high-grade osteosarcoma. She's been on chemotherapy for a long time. The imaging studies show that to get clear margins, she would require a hemicorpectomy at L2. Now the problem is how to figure out flaps to provide coverage. Or it's not worth doing if you can't provide coverage. So this is our team. You can see Dr. Rose, who's the chair of our muscular oncology division, our colleague Matt Hodek, who many of you know now, and our fellow. And on the right is our plastic surgeon, Steve Moran. And so we're working with a cadaver to try to figure out what flap we can use. And we figured out this lateral thigh flap would give us the best chance. Here's the extent of the tumor and post-op x-ray. And that flap healed beautifully. So here she is recovering. She's now at home in her bucket orthotic. So this shows the disease-specific survival. Overall, 66% at 5 years, 51% at 10 years. And the survival was greater than 50% in each subtype except for the extensive type 1A total sacrectomies. There was better survival in the primary tumors than the local recurrent tumors. So when we excluded the local recurrent tumors, survival now is 74% and 58%. Local recurrence-free survival is 81% at 5 years, almost 80% at 10 years. Metastasis-free is 72% and 60%. So the function, 80% of the patients were ambulatory, 44% ambulatory without gait aids. Now, in each group, the function really varied with the degree of neurological sacrifice. You can see type 1A, the total sacrectomy. Type 1C is the standard sacrectomy below S1. Type 2 will often have neurological sacrifice. And type 4 is actually similar to the type 1A. So in these extensive sacropelvic resections, complications are common, occurred in 78% of the series, predominantly wound problems in 48%, and deep infection in a third. The risk for complications is increased with pre-op radiation. 14 patients had hardware failure associated with pseudoarthrosis in 9 or deep infection in 5. There were 4 perioperative deaths. 3 of those were due to cardiac. So now patients have a very strict cardiac evaluation with functional testing preoperatively. So in the absence of any standard classification of sacropelvic resections, we developed a classification based on the extent of resection and the need for a hemipelvectomy amputation. We found that we're able to predict is effective in predicting the surgical approach, the type of bone and soft tissue reconstruction in each group, and the sphincter and ambulatory status. There's 50% survival in all but the total sacrectomies, and as you saw, the functional scores parallel the neurological sacrifice. There remains significant morbidity, but there's a great deal of effort and research been done in each of these disciplines to try to minimize this. So thank you for your attention, and it's a pleasure to participate.
Thank you, Dr. Sim. It was a pleasure to listen to you once again. Very enlightening talk, especially the new classification. Again, we'll keep the comments, questions till the end. We will now move on. I will cover pediatric hemipelvectomy and share a few of our cases. Okay, I'll take you through our experience of internal hemipelvectomy in younger population that is below 18, and what are the challenges and some of our outcomes that we were able to achieve. Just for the interest of young participants, internal hemipelvectomy involves a local resection of a lesion, including all or part of the hemipelvis, while preserving the ipsilateral extremity. Opposite to that is external hemipelvectomy, whereas the previous speakers showed we removed the whole lower limb with the pelvis. Hemipelvectomy is performed either for primary bone tumors or soft tissue tumors arising from the bone, pelvic bones, or around the soft tissues of the pelvic bones. And I said external pelvectomy, where you can't preserve the nerves or the vessels, it is better to do an external hemipelvectomy, also favored in palliative cases where a prolonged recovery period is undesirable. What are the challenges in pediatric population, where the limb sometimes is very small, the organs are small, the pelvis is small, the vessels are very delicately small, and so are the nerves. The bony architecture is immature. We have growth plates, the triradiate cartilage, sometimes acts as a good biological barrier. And we need specialized post-operative care for these patients. They are not managed just like adults. They have specialized fluid requirements. They have specialized pain management doses. And then obviously also the transfusion titration has to be done according to the weight and age of the patient. Managing these cases in our part of the world obviously demands that you have special interest in doing pelvic surgeries. You should have adequate training by way of a fellowship or attachment. You must be very familiar with delicate anatomical structures that pass or traverse the pelvis. Our indications have to be very appropriate, and so has to be the instrumentation, and we must have a research interest, otherwise we are no better than technicians. These have been my mentors, and everybody knows Professor Muhammad Umar, Dr. Sim, and Dr. Donati in Rizzoli. And we have published something. Our data is gradually growing, and inshallah we'll publish also our pediatric hemipelvectomy experience. This is how I take a position when starting a pediatric pelvic case. I have a special headlight, and I wear magnifying loops of 3 times magnification. They help me, and the light kind of focuses on the area, especially when you are dissecting near the SI joint area. So that is helpful. So we covered the staging, and one thing to emphasize, especially for our local participants, is an orthopedic tumor board, which we have now regularly at our institution and now at many institutions across Pakistan, where multidisciplinary teams participate, and we discuss and plan management for all these cases in a more or less unanimous fashion. I have used utilitarian and CN most of the times, the classification, extended if you go into the sacrum. Sometimes you have to take the viscera also with it. So our experience is from the last 10 years of about 17 cases. Males mostly, minimum age was 5 years, going up to 17. Most of our cases, surprisingly, I dealt with were Ewings, 2 osteo and 1 synovial. Biopsy done outside for most of them, as the case still are not following biopsy principles as were alluded to by Dr. Zishan. These were our hemipelvectomy, the combination of 1, 3, 1 and 2, sometimes 1, 2 and 3, and sometimes going into the sacrum also. Most of the reconstructions I did were free suspension type, where I just suspended the lower limb with the remaining ilium or sacrum with a muslin tape or a very tape-like structure which would hold on, and we would give them 1 kilogram of traction post-op with a derotation plaster boot, and that would keep their limbs straight and in line. So I don't apply spicas to them, and they within the 8 to 12 weeks they form a pseudocapsule, strong pseudocapsule, and after about 6 to 8 weeks I allow back to chair mobilization, and after about 12 weeks I allow them gradual progressive weight bearing. Did 2 acetabular, partial acetabular resections and reconstructions, and I'll show you the examples. No reconstruction was done in 5 cases. Obviously, a lot of teaming up with plastics has to be done, as General Saab mentioned, and a lot of them required a flap. The margin status, we did have our share of positive margins in 1 case. Wound infection was the major problem, but again, 5 cases ended up with some form of nerve injury, either the femoral or the sciatic, and some had flap necrosis and 1 had local recurrence. Our cases expired also. That patient's local recurrence expired. 4 patients developed metastatic disease and expired. 1 had chemo-induced complications, and 3 died of non-oncologic causes. So our disease-free survival overall was 70%, with a median follow-up time of about 72 months. And our overall survival was, with a median of 33 months, was about 53%. Now, some of the cases, 14-year-old boy with Ewing sarcoma required a type 3 hemipelvectomy, lesion in the superior acetabular ramus and part of the anterior column, where we did a very limited resection post chemotherapy, and we only removed part of the superior pubic ramus, preserved his ischial ramus as much as we could. Operator nerve had to be sacrificed. This is the middle X-ray, 7-year follow-up. That was the resection that was done. This is the scar that was done, and this is the functional status that he has now, ambulant full weight bearing without any pain. This was a 6-year-old with the Ewings of the hemipelvis, where we did a combined type 1 and 2 resection. So after resecting the acetabulum, my challenge was to hold on to the lower limb, and I just taped it with the remaining ischiopubic confluence, and applied the traction and boot methods that I described. But gradually, as he has walked over the last 8 years, the femur has been progressing up, and the pseudofibrosis is not strong enough, and he has developed shortening and is limping, and as you can see, developing some structural changes in his spine also. So something has to be done sooner or later. He's still disease free though. So the resection, and this is his gait now. So he still has a limp. He can squat. And his limp is increasing. So we may have to go for a femoral-ischial arthrodesis sooner or later to kind of get away from that problem. So another 16-year-old boy with synovial sarcoma. We did a T1 resection, preserved his hip joint, and did no additional reconstruction. His hip joint capsule was preserved. This was the resection, and this is how he walks now with some limp, but can walk independently, put on considerable weight by now. These are cases where I did a hemi-acetabular resection in order to preserve the growing acetabulum. This was a type 3 combined with a partial type 2 resection. Ewing sarcoma of the pubis, shown on the picture on the left, and part of the ischium, where we removed the pubis and ischium, the anterior wall of the acetabulum, the medial wall of the acetabulum, the posterior part of the posterior wall of the acetabulum, but the dome was preserved, and I attempted a bone graft fixation with screws to stabilize the hip joint and to kind of provide a artificial acetabulum coverage. But as we see, this middle picture is a 3-year follow-up, and the bone graft is gradually absorbing, but his head is staying at his original place. It's slightly migrated medially, but not much. And the video shows us that he still has a limp, but is kind of can do an SLR also, and it's reasonably pain-free, and he can bend his hip and knee reasonably well. The other case, your 7-year-old boy, he had Ewing sarcoma, huge sarcoma of the pelvis to begin with, crossing the midline, and also had chest mets. So this was the stage 3 Ewings, where we did a full course of chemotherapy, neoadjuvant, then we had tumor board, and we discussed. Then we kind of radiated his chest, completed the adjuvant chemotherapy, gave him the full advantage. Then the tumor kind of shrunk considerably, and we were then able to resect it completely with a margin-free surgery. So it was a combined, again, a type 2 and 3 resection, where I again reconstructed the acetabulum with bone graft and tried to preserve his hip joint. So this is the X-ray after, in the middle is about almost reaching 3 years. He was stage 3. We now have 3 cases of stage 3 Ewing's where we have done concurrent radiotherapy to the chest and the pelvis. And then surgery comes in the end, where once we have finished chemotherapy and radiotherapy, then we have embarked on surgery. So this is the patient with the longest follow-up of about 3 years. This is video, gait, obviously has a limb, but I guess kids absorb a lot of pain also. They don't show too much expressions of pain. So these are challenging. This is a challenging disease and challenging patients to do them in younger kids. You need to have passion and be able to face the challenges and complications. The complications are many. They can kind of, I've been depressed with them sometimes. You need to learn how to get out of that depression. And you need to develop your experience concurrently with pelvic courses, with cadaver dissections. And now we have also on the research side, since last 5 years, we are maintaining a tumor data registry that helps us to bring and review our results, bring out publications, and those are the good aspects of doing these challenging work. So thank you for your attention. I would now move on to some case discussions I have for the group. We are already about 5 minutes above the time, but since we started at about 15 minutes late, we can take the liberty of discussing 1 or 2 additional cases I have. So this is our first case for today for discussion. 64-year-old male, diabetic, with hypertension and ischemic heart disease, pain and swelling in the groin for 6 months. Diagnosed case of chondrosarcoma where we did hemipelvectomy about 3 years ago. So this is initial X-ray. I don't have time to show the complete series of MRI. We have it ready on the packs, but just to suffice that his tumor was kind of entering into the anterior proximal thigh, as well as the area of the pubis and ischium, posterior anterior column both, and going up into the ilium significantly, up as close to the SI joint, almost there. So this was his MRI reading. We did a biopsy. Initially, it confirmed chondrosarcoma grade 1, but the way it was progressing and kind of almost encasing and abutting the femoral vessels, the biological behavior did not confirm it to be a grade 1. So the metastatic workup was negative. The case was discussed with the family, and we thought it would be the best thing would be to remove the tumor completely and do a wide margin excision. He was a cardiac patient, so all the pre-op cardiology workup was done. Intraoperative, tumor was adherent to the femoral vessels. Vascular surgeon was already informed. He was called and he helped us to separate the vessels from tumor. And we almost skeletonized the femoral vessel during our dissection from the SI joint level to the level even beyond the origin of profunda femoris. And as the tumor was significantly into the upper proximal thigh, a lot of manipulation of the vessel was done back and forth, medial and lateral, to take the tumor mass out, keeping a margin intact. So this is actually what was done. This is my resident, Dr. Junaid. He must be complimented for making these drawings. And this is the resection level on the left, where we resected the whole pelvis along with the SI joint. And then I stabilized the ipsilateral limb to the sacral bone with long shank screws into the S1 cancellous bone. So this was the resected specimen. The final histopath was chondrosarcoma grade 2, but we were having iliac resection margin, which was very closely involved, despite the MRI showing us the above margin, but we have microscopic involvement of the bone at the iliac level. Anyhow, after hemipelvectomy, the right lower extremity was only attached with femoral vessels. to axial skeleton of the body. We resected the whole iliopsoas muscle, so no anterior attachment, suspension muscle, and only the gluteus medius and minimus were also resected. Only the gluteus maximus was kind of, we were able to save that muscle only. So two big shank screws from the femoral head to the sacrum, as I just showed. Intraoperative, after closure of wound and just before shifting of the patient, we could not palpate the distal pulses. Vascular surgeon was again called. He re-explored and found a thrombus in the femoral artery, so an artificial graft had to be placed in, and we had pulses thereafter. First post-op day, he was an inotropic sport. Being a cardiac patient, he had the lethal triad of acidosis, coagulopathy, hypothermia, required a lot of transfusions on the second post-op day, was maintaining reasonable urine output. On third post-op day, he was still on inotropic sport with reasonable urine output. Posterior tibialis pulse was palpable and audible on Doppler, and he had a spike of fever. On the third post-op day, again, dressing continued to be soaked. On the fourth post-op day, he had a greenish discharge from the wound and again had high-grade fever with a right leg which now had externally rotated a bit from the original neutral position. And his posterior tibialis pulse was not audible, even on Doppler. So we discussed with the family, the vascular surgeon and myself had a long session with them. And we said we are not going to reconstruct the vessel and we should rather go for an external hemipelvectomy. Again, he was taken to the operating theater where a foul-smelling wound was found. The graft had ruptured and there were multiple perforations in the distal ileum, gross peritoneal contamination, and there was necrotizing fasciitis of the abdominal wall till the costal margin, the necrotizing fasciitis of the gluteal region. The external hemipelvectomy was done and an ileostomy was also done. He was hemodynamically unstable. He had intraoperative asystole, which was recovered. Had bradycardia also, family counseled in detail, but on the next post-op day, he had an asystole and could not be revived, and the patient expired. So issues, what were our issues here? He was an elderly man, about 64, with cardiac issues, with an extensive disease of the hemipelvis entering into the upper thigh, which was adherent to the femoral vessels, and too much skeletonization of the vessels and back and fro movement obviously led to thrombosis of these vessels by the time we were about to shift the patient. We had a makeshift reconstruction and skeletal stabilization by way of those shank screws into the sacrum and through the femoral head and neck, which possibly due to some nursing issues, we had a cutout of those shank screws leading to rupture of the bowel and then the necrotizing fasciitis of the abdominal wall, which in itself is a very lethal condition. Ultimately, we lost the patient. So discussion here is what could have been done differently. Begin with Professor Sim for his comments. What could have been done differently?
These are big surgeries, and obviously there's could be big problems, and we're all used to complications are high. You did very heroic surgery, huge resection, and the difficulties you well outlined with the adherence to neurovascular structures. I think next time you'll leave out those shank screws. Jeff Eckhart has shown in his series that with time these patients will heal in with soft tissue fibrosis and be able to ambulate. So I think that's the main issue. But I think the surgery was fine. You're able to achieve clear margins.
So how would you immobilize them, such resections post-operatively?
Well, if you look at some of Jeff Eckhart's videos, he keeps them down in bed with little traction for a couple weeks. But as you know, when we do a hanging hip, or we call a girdle stone, the iliofemoral pseudarthrosis, we do a soft tissue reconstruction. much like you did in your talk, where you reattach the remaining femur to whatever bone is left, and then it kind of scars in. So we get them up right away in a brace and get them mobilized. So the Germans used to bring the femoral head back against the sacrum and put a mesh and things to hold it there. But I think eventually they stabilize, and certainly not all patients need reconstruction. Sometimes it's a preference, but certainly we have to carefully select patients that we're going to do reconstruction on.
Okay, we can take turns. Ben, any comments?
I think, that was quite a difficult case and situation in general. The surgical plan, I don't think, was a bad one. I think recognizing that this was a big tumor, the necessity for vascular surgery, all these kinds of things. The most interesting part of this is now when you have something happening post-operatively, when do you recognize it? When do you intervene? And what is that intervention? And that's always hard, but there's kind of a general rule that if something is happening that seems to be going in the wrong direction, that it's best to figure out what's going on and intervene rather than just kind of watching it. So clearly you guys had a close eye on this patient for the first few days. Afterwards, that is a tough decision to go back and complete external amputation, but likely in this patient, the right one, given the situation at the time. It doesn't happen often, but occasionally there will be, blood loss and bleeding and saturated dressings after surgery. If there's drains in, the drain output is very high. Occasionally there can be issues with continued bleeding where you have to go back in and pack a wound or tie off the internal iliacs or something like that. So I guess to me, it'd be difficult to say what could you do differently. If there was a bowel perforation, I would say that's maybe the one teaching point, but occasionally just complications will happen. But the point is, don't ignore them. And even if what you have to do is big and distasteful, if it's potentially to save somebody's life, then that's the obligation.
So Ben, if you were to handle this case, would you ever consider a primary external hemipelvectomy?
No. I would have done what you did, the internal hemipelvectomy, and I would have not reconstructed, given the amount in the ileum. I would have done some kind of attempt at soft tissue, pseudarthrosis, fibrosis, however you want to call it. I probably would not have done internal fixation and just counseled the patient that the recovery would be quite long. They'd likely have some functional limitations. They'd have a short, painless limb. It would take 2 years to recover, but that they would eventually obtain some stability of the hip joint.
Right, thank you. Dr. Sohailafeez, you were about to say something.
Masood, the way I look at it is that the limb itself has a lot of weight. Most of us who had been doing the house job would vouch for it, how much a limb weighs once the consultant hands you over to hold the limb forever. Anyway, if you have done an internal hemipelvectomy, to my mind, either you leave it alone completely, like a congenital, like a pseudarthrosis, don't hang it anywhere else. But if you are trying to fix it, I think it would be better to fix it properly. That's my logic of putting in struts and reinforcing them with a recon plate. Although I'm still very cautious in mobilizing these patients. I think the thing which went wrong was, I would not use word inadequate, but not optimal stabilization which you were trying to attempt. So if one has to, either one does like a pseudarthrosis completely, leave it alone, or if you really want to fix it in a way that it has some stability in the next 4 to 6 weeks. That would be my take. Otherwise, I think you did a wonderful job, great surgery. These things do happen in such big surgeries.
So, Dr. Sohailafeez, my question to you would be, what is your experience of a post-op before you shift the patient a total blockade of the ipsilateral main artery, especially in a very perivascular tumor?
I did have one bleed that there was, and we went in back in again, but that was a strip ligature in one of the branches of the common femoral. but I probably I don't have enough cases. I can only count about 15 to 20 of a pelvic surgeries, pelvic tumors that I've done so far. I think I'm still lucky.
Okay, thank you. Dr. Zishan, any comments?
Dr. Masood, in probably about a dozen of internal hemipelvectomies where I've used the hanging hip or some sort of soft tissue reconstruction, I've had two cases almost similar to yours where I've had problems with vascular occlusion. One was an elderly, not an elderly, about a 36 years old lady, where we did a P1 to P3 resection and we suspended the hip with merceline tapes, both from the contralateral pubic rami and from the sacrum. And 18 hours later, she ended up with a cold, dead leg. Probably some issues on nursing part as well. And we ended up doing an external hemipelvectomy on her. That lady subsequently passed away because she developed secondary skeletal metastases. Recently, if you remember, I gave you a call and discussed the options of iliofemoral arthrodesis and how you immobilize them just a few weeks ago.
Exactly.
And that girl in whom we did a P2, P3 resection, we did a pseudoarthrosis, iliofemoral, and she did really well till the middle of the night on day one post-op when my resident called me and said that she wasn't happy because the leg was feeling cold. So I had to come back in and we did an urgent arteriotomy to find a big clot in there. We did an embolectomy and a fasciotomy. She still has some residual common peroneal nerve damage, but we managed to save her leg. So in two of the cases, I've had similar problems. I'm not entirely sure. Both of them were females, both slightly bulkier. So I don't know how much of a soft tissue and this merceline tape weight will be taken over by these. It's difficult, but in the era of limb salvage surgery, one tends to go away from external hemipelvectomies straight away. Although being trained in Birmingham, I know that the Birmingham group are now more and more with their published data regarding local recurrence and upgrading of chondrosarcomas from the initial histology. They're doing more of external hemipelvectomies as well. So the jury's still out. We need to have a look, but safety and margins should take precedence over limb salvage, I think, which is the common sense ahead.
Great, thanks. So any other comments from the faculty? I had about 4 cases, but in the interest of time, we would just do another one, a small, another reconstructive challenge, as I would put it. So this was a 24-year-old female, no comorbids, pain and swelling, right groin, 4 months, progressive in nature, and the x-rays were like this. This was a very educated, well-off family, but they were kind of ignoring this pain and swelling, which was gradually growing in the groin. And so I did an incision biopsy. This was a deeper thing, so I did it under GA and general anesthesia, and it came out to be chondrosarcoma grade 2. Metastatic studies were negative, and we, after significant and detailed counseling, planned for a right internal hemipelvectomy. This was our surgical plan. This is what our residents draw up before we embark, and this is pasted on the operating room wall, how much to resect, what to resect with a drawing. So just my effort to make them learn of doing some pre-operative workup for every tumor resection patient, and try to draw the area with the amount of muscle and soft tissue involvement, and usually they write the lengths of resection, proximal, distal, medial, lateral, everything. Here, that's usually in appendicular skeleton. So we utilized the utilitarian approach, and this was the post-op thing. This was the initial X-ray, as I showed you. This was our resection plan, and this was the resected specimen, and this is the reconstruction that I did. So actually I did nothing. I resected the anterior and posterior columns, spared the dome, and kind of loosely attached the femoral head to the remaining acetabulum. Now, and obviously then I used the same technique of 1 to 1.5 kilogram traction and a derotation boot for about 8 weeks, and then gradually mobilized her from bed to chair position to to gradual ambulation by about 3 months time. And I think, Ben, you have seen her when you visited my clinic. You met her, I think. That was a big consolation for her. She was very worried at that time. So clinical course she had in the last 3 years, she has had 2 full-blown episodes of cellulitis of ipsilateral thigh. And we don't have any metal up there, so I did a workup of color Doppler, which was negative for any DVT. She required IV antibiotics, hospitalization twice in last 3 years, although every time the cellulitis resolved, the swelling and pain is also resolved. So she underwent gradual rehab with improvement in limp and pain. And this is her current video. Yeah, we can see it now. So this is this lady now after more than a year of index surgery. I think she's almost nearing 2.5 years. She can walk without support. She has a mild limp. She doesn't have too much pain. She can do her household chores. She can even mop the floor, as she told me, and kind of reasonably very satisfied. So current issues are she has a mild limp with very minimal pain, but wants an implant done. How long will this reconstruction last? I'm not sure. Gradually, she's improved in her pain and limp, and there are obviously risks involved with putting in an implant here. The implant can be done and they can afford it. So affording is not a big issue here, as is the usual case in our part of the world. But the risks involved are that she's had 2 times very bad cellulitis of the thigh, probably secondary to lymphedema, which she had initially, which kind of resolves with IV antibiotics, 2 hospitalizations, 2 weeks of IV and antibiotics each time. So what would be the recommendation of the faculty? I can put back the post-op X-ray for a better discussion. This is 1 year X-ray. She almost has a more than 2 year follow-up now. So we can start with, again, the same sequence. Let's start with Dr. Sim, please.
Yeah, very nice. That's a well executed plan. And you say bone stock. So I think it'd be reasonable. Now the cellulitis is the main concern, but with the bone stock you preserved, it wouldn't be difficult. We have a group in our, we've reported in our tantalum reconstructions we use off-the-shelf tantalum implants to kind of do a custom fit to the remaining bone. And all the patients had good ingrowth with osseointegration. So I think it's possible. In that group, there were, I think, 4 patients or maybe 5 that had a secondary reconstruction. So I remember 2 of them had arthrodesis we took down, and 1 or 2 had a painful pseudoarthrosis like this. So you certainly have enough bone to do that, and you could do a custom implant with 3D printed implant and models and so forth, or off-the-shelf tantalum that works good depending on the amount of bone you have. So we have 1 patient that had lymphedema and cellulitis, and that was always concerning. So I think our ID people have him on pretty constant oral antibiotics. But a very nice job, and now you have your options for reconstruction.
So Dr. Sim, would you keep them on a long-term antibiotic therapy after an implant?
No, once they're healed, and drains are out. But in the patient had the recurrent cellulitis, he had a lymphodematous limb, and he was using all of the vascular support hose and pumps and stuff. So he had recurrent episodes enough that they kept him on his oral antibiotics.
All right. Thank you. Dr. Ben, do you have any comments, please?
Yeah, thanks. I was muted before, but I do remember this patient in clinic. I remember her, it seemed with her exam, her problem was instability as much as it was pain. I remember she kind of had to stand on this limb and then shift her body weight. So I get the sense that the hip is kind of subluxating in there, and that's what a lot of her dysfunction is. I think what we said with her is she was only a year out. She's had this progressive cellulitis to say, let's give it another year. At 2 years, that's what you have. And you can say, hey, do you like this? Are you able to just keep this, or is it not functionally what you want? And then I did think some kind of surgery would be reasonable. I think it's important with her to make sure that she knows her expectations. She's very intelligent, but also pretty high demand to know, this is a big procedure. There's no guarantees with anything. And just to make sure that the goals of what you were trying to obtain were what she had in her mind. You're not doing this so she can participate in the Olympics. You would be doing this perhaps to alleviate pain or give her more stability, but there's some inherent risks involved. And then I would feel the same. To me, this looks like you can build it up with some element of a standard or custom hip replacement. I'd probably get a CT scan to see exactly what kind of bone is left there. If you have enough, potentially you could just do like a high-end growth tantalum type revision cup. If you have access to augments, perhaps an augment, and then something custom made would be another option.
Would a cone be an option?
Cone, as in like the ice cream cone acetabular reconstruction?
That's right. Mm-hmm.
Yeah, something like that. I think, to assess what kind of bone you have left. We don't have too much access to those cone type reconstructions in the US. It's more either modular hip revision strategies versus a custom implant. Those are the two things that we work with. But I think there's plenty of bone really for anything you would want to do.
Sure, thank you. Dr. Suhail Hafiz, please, what would be your choice of reconstruction here? Now, or either primarily or now?
Her age, what's her age?
She's 24, sir.
Well, isn't she a bit young for, even if you put in the best implant, the chances of aseptic loosening would be quite high in the next 5 to 10 years. So I would rather wait her through more time till she earns her surgery. I would not be very keen to put it straight away because she's too young. Cellulitis is another thing, but her age is very less.
So how would you reconstruct if you were to do this surgery? What would be your choice?
Maybe an iliofemoral arthrodesis might be a good option here. Long lasting.
You would use a cobra plate or something like that?
Yep, maybe.
Dr. Zishan, what would be your choices?
I think Dr. Masood discussed quite nicely. The most important thing to understand and appreciate here is patient expectations and a realistic discussion from the surgeon side with the patients as to whether we can meet her expectations or not. That is the most important thing. I think she should be considering herself lucky that she came to a good center and she's had decent surgery and a good execution of plan. Looking at her video, although it's short-lived, it's just a year and a half or so, but she seems to have very good function. So I would sit and talk to her. I do get some of these patients who want these fancy prostheses because they've seen some videos and stuff like this. What she needs to understand, and as we've discussed, is the longevity of these implants. Yes, I've had experience of using these ice cream cones during my fellowship in Birmingham, but their survivorship isn't that great because part of it relies on osseointegration if that ever happens, and that is based on that very small narrow stem that goes into the iliac bone. And you being a pelvic fracture surgeon very well yourself know that piece of bone between the inner and outer table of the iliac bone is very narrow. So how thick a rod can you put in there? And to augment that for stability, you rely on cement and further screws. So that's not a very strong, solid implant that will live through the life of this patient.
The other option, as Dr. Simmers mentioned, is to construct some form of an amalgam with the TM augments. The TM augments, as we all use them in revision surgery, have shown very good promise. But again, their results are not as long. So we need to see how they will behave beyond 10 years. So in a nutshell, yes, we can make up some very fancy X-rays, which we can show very nicely in meetings, but will that be long lasting, and will that actually address her concerns? That is the main thing that we need to discuss with this patient.
Right. Thank you, Dr. Zishan and Dr. Sohail. If I can take a couple of questions from the audience also, they've been waiting for the last 2.5 hours now, bearing our talk. I hope you have learned something useful today. But question from my colleague Atar Siddiqui, who is now in UK doing his fellowship, for Dr. Sim. Dr. Sim?
Yes, sir.
The proximal femoral flip that you do is pedicled, free vascularized, or non-vascularized that you showed?
The proximal femur is non-vascularized, and we may do that right away, but usually it's a secondary procedure, so it's put in the deep freezer until the staged reconstruction. But if we're able to preserve the vascularized fibula with a long flap, then that augments it. You saw one of those cases of fibula was used as well. Mm-hmm. And so the construct is very stable.
Yeah, okay. Thank you. Another question to Ben Miller, which he kind of addressed also, but sometimes chondrosarcomas are so big they're adherent to rectum and bladder and occupying almost the whole pelvis. How is it possible to achieve margins, and what is prognosis of these tumors when margins are not clear of tumor?
Well, yeah, for chondrosarcomas and really any sarcoma, you can start to have issues with margins. So I think this is where preoperative planning really comes in as significant to make sure that the correct services are with you, helping you on these operations. The general trend of sarcoma is to push and to not invade. So many times, even if there's substantial displacement of these structures, they're not involved with the tumor, and you can find a clean margin around it. But you're not going to be able to obtain the 4 millimeter Birmingham recommended margin without resection of a bladder or rectum or something like that. And now you're into a discussion of, is that truly necessary, or are you willing to accept a lesser margin for better function? So I think these must be discussed on a case-by-case basis. But for me, most of the time, all of these structures are able to be maintained. The issue is just visualization and having the appropriate help in the operating room. And then what are the results? I think it really depends on the patient. And we know that a number of these, a third or more, will recur. And most of the recurrence would be due, assumedly, to residual disease. You know, we call them recurrences, but really what they are is they're just expected growth of residual tumor. So it certainly speaks to the complexity of these cases, that every case has to be individualized and scrutinized. For me, most of the time, though, even if it's next to these important structures, I find that they do not have to be sacrificed, that they can be salvaged with a narrow margin. But there certainly is a higher chance of recurring locally with that approach.
Right. I think that answers it very well. Another question, and I think we should make it the last question, to Dr. Zishan. What is your approach to take a biopsy from supraacetabular or acetabular tumor? What is your approach?
So, as we discussed in our talk, it is usually incorporated in our utilitarian or the Ollier's approach. So it is basically in the supraacetabular area, but again, depends on where it is in relation to the acetabulum. The principle always remains the same. It stays within our definitive approach.
Yeah, exactly. So, Dr. Zishan, on the same lines, you do these biopsies under anesthesia always, or any role of clinic biopsy or a biopsy under local anesthesia?
So when I was being trained in Birmingham with Prof. Grimer and the team there,
I was very, very kind-hearted, and we used to do all those biopsies under general anesthesia with good fluoroscopy control. But since I came back to Pakistan, I noticed that the limitations and the logistics are quite different. And seeing you and discussing lots of things with you, I started doing them under local anesthetic, still in theater. I still have not gained the heart and strength and confidence of doing them in clinic yet, but I still do them under local anesthetic in theater. The only exclusion being pediatric patients if they're less than 14, and if I have a very anxious patient or deep-seated one. Otherwise, most of them are done under local anesthesia.
Thank you. In the local context, Dr. Sohail Hafiz, you have any comment to add from the biopsy perspective in our local context?
In our setup, we take all our biopsies are taken by our radiologist. We have a very good interventional radiologist. The only thing that I ensure is that I mark the line through which he should be going, which should be as direct as possible, of course, considering the ultimate surgery. And then after he has taken the true-cut biopsy, we actually mark that site so we know where that biopsy track is. I've done a couple of open incisional biopsies only if we found that the report was inconclusive. And of course, the principle remains the same, that my biopsy track would be through the same region where my ultimate incision would be. But answering you, most of my biopsies are done by our radiologist.
Right. Thank you. I think I have almost more than 10 questions, but in the interest of time, I think we should stop here. I must thank my panelist faculty members for taking this precious time out. We have already shot 46 minutes over time, which is a bad time management in itself. But anyhow, considering the technical hitches that we always have with such webinars, I think overall we did a good job. So I must thank Dr. Franklin Sim, Dr. Benjamin Miller, General Sohail Hafiz Saab, and Dr. Zishan for taking time out today and helping me in contributing to this webinar. And I look forward to holding such webinars on regular occasions and would be seeking your help in future also. So thank you very much. Appreciate your help.
Wonderful meeting. Thanks a lot.
Great job, guys.
Thank you.
Thanks, everyone.
Look after yourself.